everyone. I am Dr. Brajesh. I am senior interventional cardiologist in Apollo Hospital, Navi Mumbai. My special interest includes coronary artery disease. As an expert interventional cardiologist, I always one of the aim of my treatment or to prevent the restenosis or to prevent reblockages is the lipid lowering, and one of the target of lipid lowering is of course the LDL. Now, we have been saying that the LDL is probably the most important factor which is responsible for atherosclerosis. If you know the Interheart study in which 10 factors were studied for coronary artery disease, and lipid was considered as the most important factor causing all heart attacks, and 50% of all heart attacks used to caused by high cholesterol. So based on that, new and new guidelines keep on coming, new and new drugs keep on coming, and the question still persists: how low you need to go down to the LDL. So let's go one by one to the questions which we have. What are the optimal and safe target for LDL levels for high risk ASCVD patients? Now, see if you see the guidelines. Basically, we follow two guidelines. Various levels of targets have come, and if you see the recent guidelines of ACC/AHA and the European Society of Cardiology, you find that the LDL level for a routine patient who doesn't have any risk factors, doesn't have a previous history of atherosclerosis, the level recommended is 100. And if you see the ADA guidelines, the American Diabetic Association, if the patient has got a diabetes, that itself make the patient vulnerable to have a coronary artery disease. And for that patient, the LDL level recommended is 70. But suppose if there's an evidence of coronary artery disease and patient has undergone an angioplasty, then the LDL level should be less than 55. More importantly, the Indians, we have a Lipid Association of India guidelines, LAI guidelines, which says that patients with a known CAD, the LDL level should be as low as 30. So I think it is important to keep the LDL as low as possible. If you see the most recent guideline, which is 2024 guideline, you find that the LDL level in these patients are recommended level 2024 LAI guidelines. The LDL level in a very high risk patients is recommended to be 15. So that is the situation of LDL levels right now. Okay, can you go to the previous slide? Okay, previous slide, previous year. Okay, so next. So that is what I said: strike early and strike strong. Now, we have multiple medicines available in the treatment of high cholesterol. We all know this, the statins, where we have rosuvastatin, which is also known as superstatin. Then we have combination of drugs like bempedoic acid and ezetimibe. Now, they all have roles, but we have certain populations in whom the LDL level is not reduced in spite of using maximum doses of statins, in spite of using combination of drugs to reduce cholesterol. For example, combination of bempedoic acid, ezetimibe, and rosuvastatin, all three together has not caused significant reduction in LDL cholesterol up to the guidelines. So we are still in search of probably better molecules which can reduce it. Now, initially, this evalucumab gave us some, chances of further reducing the LDL. But the problem with evalucumab is it has to be given every 15 days, and not many patients are happy to take it every 15 days. So that is one of the thing, and there have been incidences of certain side effects with evalucumab, which as it is a monoclonal antibodies. So to sort out these issues, I think one of the agents which is probably the best which can be used right now is inclisiran. Now, why it is important? Because the inclisiran is a small interfering mRNA, RNA. Now, this RNA works through the genetic pathway like scenario. It does not have effect on the biochemical pathway. It does not have effect. It's not an antibodies. So by doing this, it's almost devoid of any side effects. That is the best part of this molecule. Next. This all I have discussed. Next. Next slide, please. So that is the reason why this inclisiran has come into the market, because it has to be given once 6 monthly, even though the recommended is 0, 3, and 6. Many of us we are skipping the third month dose and we are giving 1, 6, 12 like that. Now, what are the indications of inclisiran? See, as I said, any patient whose LDL levels are not controlled in spite of using all oral drugs, or the patients who have developed certain side effects of statins, because of, statin causes a lot of side effects like hepatotoxicity, myopathies. People don't tolerate it well, so that is the reason inclisiran can be used in those places. Another a good example of why we should start using inclisiran is its effect on lipoprotein A. Only few molecules they act on lipoprotein A, and lipoprotein A is considered as a very strong genetic factors causing coronary artery disease in patients. So we have been seeing patients who have an accelerated atherosclerosis, patients who come recurrently with the stent thrombosis, stent restenosis, their lipoprotein A levels have been very high. That is the reason why inclisiran is good. In many of the trials, the inclisiran has reduced the lipoprotein A by almost 40%. Reduction of LDL cholesterol with inclisiran is almost 50%. So if you give this, you end up in not only reducing the lipoprotein A, so it will also reduce the LDL cholesterol. And most importantly, it is devoid of any side effects. Next question is, where does the inclisiran fit into dyslipidemia? Well, uh, see, not many patients are happy when you give a cholesterol medicine to them and tell them that this need to be taken lifelong. Daily medicines of probably once daily, everyday dosing with a molecule where so many things have been written in the Google regarding the side effects of statin. People are scared of using statins. Many of my patients, when I prescribe them statin, tell them that you need to take this lifelong. They do ask me questions: what are the side effects, and does this statins patients on statin develop diabetes? That is also one thing which is very commonly spread in the society, that the statins, if it given, it induces a new onset diabetes. So that is one of the things. So I think the future of management of dyslipidemia is inclisiran because of the advantages. One is the ease of giving it. Now it is just like an insulin syringe, just need to give in 10 seconds, it can be given. Most importantly, zero side effects. I have been using it. I have not found even a single side effects. Number three, its additional effects, like for example, on lipoprotein A, which is very good. Long duration. That means 6 months. In 6 months, if you are using it, there's no molecule which can work like that. And very importantly, what I feel is we are heading towards something like a vaccination for atherosclerosis. Now, like vaccines are given, flu vaccines every yearly, the time has come that we start thinking about atherosclerosis as a disease per se, and and patients should be vaccinated with it. So that is very very important. So I think slowly and slowly, inclisiran is the way ahead. Oral tablets, probably because of the side effects, may not be a treatment of choice for many of the patients. Patients who have myopathies already, patients who have a liver damage already, patients who are not able to control cholesterol in spite of maximum dose of statin, patients who have side effects, patients who are not willing to continue oral tablets. This molecule is going to bring revolution in the field of dyslipidemia. So I think soon inclisiran is going to be class one. It's preferred over statin. Right now, the injectable agents are class one only when the oral therapies are not able to, sort out the required level of LDL. But soon I think it will cross the statins and probably be the number one, number two. So I have already gone through this. So I think the approval is already there, especially for patients who have a familial dyslipidemia, patients who have statins intolerance or statin resistance. So it is already there, and it can be used in combination with statin or standalone therapy in patients who are not tolerant or who have not achieved the target with inclisiran. So I think I've already said patients who have, statin not able to control the required cholesterol levels, statins causing side effects, and patients who have an additional lipoprotein A level being elevated, patients who have a hepatotoxicity, patients who have myopathy, our patients who are not willing to take daily medicines. I see patients say, "Sir, why?" There was a patient from Zambia where he said that it's very difficult to get statins in his country, and can you do something where maybe I can come once in 6 months and take the stock? I said, you don't need to take a stock. Just take this injection and come back after 6 months. I will give you another injection. So something as comfortable as possible. I mean, you cannot dream of. So I think these are the patients who will benefit more. So we all know it's a 284 milligram subcutaneous once in 6 months, but many companies, most of you people are recommending an additional dose on third month. So 1, 3, and 6 probably is the 0, 3, and 6 probably is the dose which is recommended in every 6 monthly. So a missed dose means what? I mean, it's the window period. It's almost work for 6 months. Even if you miss the dose, you can take 1 or 2 days before and after. There's hardly it's going to make any difference. So treatment transition from monoclonal antibodies, yes, it can be done. I think uh, if you can within 1 or 2 weeks of gap, you can give. PCSK9 inhibitor. I think the mechanism of action is totally different. So I mean, the side effects also will not be left, will not be more. So I think you can completely change over. So it can be given immediately after the dose of Ipata or monoclonal antibodies. So which patients suitable for implants according to global and national guidelines recommended? As I think I have already discussed it. The three patients, the side effects, the intolerant patients, patient not achieve the LDL required LDL level. Yeah. Next. Okay, CSI guidelines. I think the same thing. If you're not able to achieve the LDL, so it is there in the guidelines already. Nice guidelines. I think ESC, ACC. It is there in all guidelines where probably it is not recommended as a first line. It is recommended only if the patient is unable to control LDL in spite of using maximum statin doses, combination of doses, combination of estimate bempedoic acid. So probably the next injectable is inclisiran. Okay. So inclisiran clinical insights, understanding pivotal phase 3 trials. Okay. So we all know Fourier trial, what all things it has shown. Orion 9, Orion 10, Orion 11, all has shown that 50% reduction in LDL, 50.7% reduction in effective LDL reduction. As I said, around 40% reduction in lipoprotein A. A huge benefit, in fact, inclisiran has also shown to increase the LDL. Both triglyceride levels have been reduced, HDL level has improved. So lipoprotein A has been reduced to minus 21.9. I think the long-term safety has been studied in Orion trials and has been found to be hardly any safety concern. It is liver friendly, kidney friendly, and probably muscle friendly as well. So I haven't observed any allergic side effects with this, but any injectable agent can have it. So probably if you give the inclisiran in your OPD basis, you could tell the patient to hold on for a 30 days, 30 minutes or 1 hour before he goes home. That's the only thing which I can tell. So safety profile up to 6.8 years has been already studied in Orion 8. So good molecule, probably hardly any safety concern. No carcinogenicity, no immunogenicity. So long-term safety and efficacy following up trials with inclisiran conducted show that inclisiran reduce LDL levels in long term while being well tolerated. That is the molecule we actually needed, because if you don't have any side effects, then only it's going to be a patient friendly as well as doctor friendly. That is what Orion 8 trial has shown. So, okay, next slide, please. So, Orion 4 and Victorian 2P are ongoing cardiovascular outcome trial with completion dates anticipated in 2026 and 2027. Okay, sure.